Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Hello, everyone. Welcome to another episode of the Chest Journal podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the distinct pleasure to discuss a really interesting article from an upcoming issue of the journal called Covert Triage During the COVID-19 Pandemic, a Qualitative Analysis of Rationing in Intensive Care. I'm pleased to be joined by two of the authors today, Eva Schmolke and Kathrin Knochel, both from Germany. And they're making exceptional time arrangement for us to be able to sit together and talk about this article. So thank you, Kathrin and Eva, for being here today. And if you could please each give us a general introduction of who you are and where you work, and we can start with Eva.
Okay, great. Thank you. So who am I? Well, I'm somebody who spent her entire life in healthcare in different roles. Right from the start, every schoolwork experience was at the hospital. After I graduated from high school, I volunteered a lot and then trained to be a nurse in Germany. Then I went to Birmingham in England in the United Kingdom and worked at the University Hospital, first on a medical ward and then later in critical care at a cardiothoracic unit. At the same time, I did a degree in health studies at master level. And after this, I came back to Germany and studied medicine, which was always my overall career goal. During my medical degree, I was fortunate to join Kathrin's research group. I still remember she presented a simulation study that investigated resource allocation and critical care during the pandemic, and I was instantly hooked. Distributive justice and medical ethics are of great interest to me, and challenges or questions regarding such topics have always piqued my interest. So this is how I ended up doing this research and ultimately on this podcast. And where do I work? Well, now I'm in my second year of postgraduate medical training in anesthesiology. The American and German career progression and medical training are a bit different, but I guess the best way to describe my current position is resident.
Fantastic. Thank you for that overview. That was a great journey through your career so far. Kathrin, please tell us about yourself.
Yeah, thank you so much for having us. My name is Kathrin Knochel, and I am a clinical ethicist and the head of the clinical ethics team here at the University Hospital of the Technical University in Munich. My background is in internal medicine, critical care, and palliative care. And in addition, I completed the degree in ethics consultation in healthcare. Even when I was a medical student, I was really fascinated by the question of when and how we should use what we can in medicine, about responsibility and trust, and about decision-making that fosters patients' autonomy. During the 10 years working in an ICU, I experienced that an ethical framework in place can ensure ethical decision-making, transparency, and trustworthy communication within the team and between the team, the patient, and their relatives. However, as Siuba Manuel said, you cannot simply switch on ethics during a crisis or other urgent situation. To me, this means that alongside ethical debates, we must put the arguments and the frameworks into clinical practice. And this is why I was struck by the importance of translational ethics and why I am now a full-time clinical ethicist. I'm also an active member of different professional societies, including the Ethics Working Group of the German Interdisciplinary Association of Critical Care and Emergency Medicine. In addition, I am a board member of the Professional Society for Advanced Care Planning in Germany. And my research focuses on these topics: translational ethics, advanced care planning, and since a few years, and we will speak about it here today, allocation of scarce resources.
Fantastic. It really sounds like we couldn't be sitting with better people to talk through this study. I'm glad you two conducted it, and I can't wait to dig into it. As soon as I saw the title of this study, I knew it was going to be very engaging. So let's launch right into that. The title mentions something called Covert Triage, which is a term that many people may not be aware of. How would you define that term, and what did we know about it prior to your study? And either of you could answer.
Yeah. So this is an interesting and important question. And from our data, we define covert triage as a non-transparent combination of physician-led medical decision-making and opaque bedside rationing. However, to be honest, we did not expect that at all. We did not expect we would end up with this topic when we started Eva's project. The objective of the study was to gain insight into implementation processes of the triage guideline or other triage plans in hospitals across Germany.
Yes, continuing from what Kathrin just mentioned there, we already know from the literature that the availability of resources influences the level of care and treatment. And clinicians constantly find themselves in situations where they divide their time or act as gatekeepers. And they realize quite quickly that they are not only in a one-on-one patient-doctor relationship where they can max out their available resources, but depending on where they work, they might have 10 patients on the ward, 50 people they have to see in clinics and outpatient care. So during the pandemic, all these issues were multiplied, were magnified through the sudden influx of patients. And as Kathrin said, this COVID manner, of implicit rationing, we did not expect that we would identify this phenomenon in our research data.
Yeah, it's a very interesting concept and something that I hadn't thought about, and I think we all are, all of us who have taken care of patients, particularly during the pandemic, would identify with this kind of feeling, this anxious feeling of having to control resources without really having a clear guidance or transparent guidance about it. Clearly, the pandemic was a very rife area to think about ethics of resource allocation. Is that kind of what inspired the study question, or are there other factors that inspired the study design?
Yeah, let me start by stepping back a little and providing some of our background, because Eva's study was part of a larger project. And I had only been working as a clinical ethicist for 4 weeks when the pandemic hit. And like people all over the world, I was also shocked by the pictures from Bergamo. To imagine being unable to treat patients due to such a lack of resources and to decide who should receive life-sustaining measures and who shouldn't was really horrible to me as an intensivist and as a person. And I always add to these thoughts that I never slept unwell. However, during the initial weeks of the pandemic, I did. And immediately I realized at this time that we were unprepared for such scenarios. There was a lack of a tool or pandemic triage plan in place, both at the clinic and nationally. And as a member of the ethics working group, I became a co-author of the National Triage Guideline. And Professor Alena Büchs, the director of the Institute for History and Ethics in Medicine at our university, was at this time a member and later in 2020 the chair of the German Ethics Council. They also had written ad hoc recommendations in March 2020. Together, we initiated very quickly an implementation process at our university hospital that was supported by the hospital board and the clinical teams. And it was an interdisciplinary stepwise process that included several meetings and workshops for a contextual analysis. We assessed the clinical practice needs for integrating and applying such a triage protocol according to the guideline. And at the end of this developmental process, we conducted a simulation study to prove the feasibility, applicability, and reliability of our triage protocol. The results of this simulation study prompted us to seek deeper insights into such processes in other hospitals across Germany. And Eva will continue.
Yes, regarding inspiration or motivation, for me, it was obviously the pandemic shortage and the anticipation of a national emergency that would require triage of critical care resources. Like Kathrin, I worked in a hospital during the pandemic. And with relation to the study and previous research, in the simulation study, the researchers interviewed the intensivists to understand the challenges they faced when they simulated implementing the German triage guideline in the intensive care environment where Kathrin worked. And we then wanted to go a step further and add a national perspective to understand how the preparation for a real triage situation took place, whether or how others plan to apply the guideline or maybe use another triage plan in hospitals across the country.
That's very interesting. Thank you for that background leading up to it. So now to focus on the present study, the paper that we're talking about today, could you please give us a basic overview of the study design?
Yes, of course. We chose a qualitative design. I conducted semi-structured interviews to understand triage preparation. Our target group were senior intensivists from various size hospitals across Germany, and they had to work in intensive care during the pandemic and were involved in triage preparation in their clinical area. And ideally, they were also one of the people responsible for triage decision-making should it occur.
Thank you. Once you started to compile these responses from people, some common themes emerged, including things around covert triage. What would you say are the key takeaways from this study?
Yeah, let me start with the following. Rationing happens if we like it or not. And during the pandemic, it was just more visible, more traumatic, and in the public eye. And the frontline clinicians we interviewed, who were tasked to deal with it, struggled due to the legal constraints and some lack of support. Some of them reported that these legal constraints resulted in a lack of institutional support, as they were not given permission to prepare a triage plan for their institutions. And they had seen options and the need to do so, to prepare triage and to make these decisions in the worst case. But they felt that the responsibility was left only with them. And as a consequence, they employed unofficial strategies to avoid an overload of their unit by reducing the number of admissions. So some of them rationed covertly.
We found patterns in the data and then analyzed two strategies. We called the first one informal crisis standards of care. So in short, what I heard a lot in the interviews was, I'll summarize it here with a quote. Somebody said, well, we knew we were not legally allowed to, so we did not officially triage. But what we did was just raising the standards for admission to critical care. So they triaged, but covertly. They then proceeded to describe to us how they employed more scrutiny when assessing patients. They were a lot more direct with patients and colleagues when it came to discussing poor prognosis and the risks of advanced critical care treatment. And they felt a lot more confident in refusing treatment. The second approach we found to avoid official triage was something that we named rationing by directing decision-making conversations. Here, the participants reflected that they can direct their interactions with patients and relatives as well as colleagues. So that means when resources were available, they described themselves as more open for discussion. They would present treatment options in an open-ended, neutral way to achieve informed consent. Yet, during times of shortness, they covertly try to dissuade patients from seeking critical care treatment, for example, by stressing the risks of ICU treatment or presenting the benefits of a less resource intense option. So all in the hope that the patient chose the option that will not block the intensive care unit. And that wasn't good for the professionals. They were afraid of legal implications. They felt between a rock and a hard place emotionally. And lastly, it goes against everything we normally hold up in our practice. Being transparent, non-discriminating, providing clear documentation and reasoning for our intervention. So they were seeking guidance and support, and they were always really willing to do their best in this public health emergency, but sometimes they had to resort to such strategies.
That's very interesting. I think that's something that probably, and I'm sure extends, beyond the confines of the hospitals that you studied, because you can imagine how people would feel the overall caregiver strain and hospital strain would impact the way that people would even just talk about what could be offered to patients. We kind of started to get into this a little bit, but just to emphasize it, did you find anything particularly alarming about your results from like an ethical or legal perspective that you found?
Yes. Firstly, I think I want to focus a bit on the legal aspect of triage, as this was brought up by most participants as a barrier for official triage and a cause for covert triage. And I just want to stress it again. It was a surprising finding because we did not expect it to be such a massive issue in clinical practice. When we designed the interview guidelines and came up with questions and topics, we anticipated that the decision-making process or the criteria used to allocate resources would play a more important role for the participants. A bit of background here. In German healthcare and in our medical culture, we do not unilaterally withdraw life-saving treatment, except for cases of imminent death. So doctors then were afraid that they had to triage and maybe even reallocate resources against the expressed will of the patient or their relatives. And then they might be liable for damage. There is no legal precedent for these types of triage in Germany, namely if the clinician would have to actively end and withdraw treatment due to a shortage of resources. But, however, that was the exact dilemma that our participants feared most, and that they anticipated due to the circumstances of the pandemic, having to reallocate resources. And even legal experts in Germany, they argued about the ways of triage, but in the end, they could not agree on the legality of triage decision-making. So the clinicians in our study, they erred on the side of caution. I remember one participant saying the following. I'll read a quote to you. She said to me, "We discussed officially triaging in our team, and some of us were even ready to set a precedent. But the majority maintained that they will not risk going to prison, even if they felt they acted in the medical and ethically sound way." Another participant told me that the hospital's legal department explicitly denied any official triage activity or policies due to fear of litigation. So this, in this case, ended all official preparation. And speaking to the ethical perspective, I just found it really challenging to hear as a clinician myself that the clinicians felt they were left alone with these issues. The guideline was designed by medical societies, which in the end are just groups of clinicians again. And I'd even say I'd found it alarming that it was necessary to resort to such covert strategies like unofficially and inconsistently raising the threshold for intensive care admissions or directing your decision-making discussions and consultations in such a way that the patient hopefully chooses the more conservative and less resource-intensive treatment. And as we discussed it before, this goes against our core values and ethics in medicine, like transparency, informed consent, honesty, shared decision-making, and such topics.
Yeah, thank you for presenting the results, Eva, and let me summarize it a little bit at this point. We took 3 important topics from our results. Firstly, a lack of legal regulation can discourage the implementation of ethical guidelines. Secondly, professionals at the micro level of a healthcare system had to face responsibilities themselves. And finally, intransparent decision-making might occur as a consequence. And in short, neglecting the topic of allocation is dangerous for healthcare professionals, patients, relatives, and the public.
That's an excellent summary. Thank you. Hearing a lot of the sort of clinician caregiver distress in making these decisions, and it's as much as we don't want to think about this, similar circumstances will occur in the future, whether they be pandemics or other situations which cause resource limitations. What are the key lessons for those future scenarios that we can take away from this study?
Yeah, let me start with the pandemic. We have seen that even the German health system, which is generally considered to be one of the best performing and most cost intensive in the world, was not sufficiently prepared for the challenges. And we wish that a pre-pandemic planning period would have allowed a better preparedness and a greater outreach to the public, in particular to marginalized and disability groups. Therefore, we should take the lessons from this now. It is essential to put effort into analyzing the pandemic. There has to be examination from social, legal, ethical, medical, and finally, political perspectives. We need transparency, interdisciplinary implementation research, scientific communication, and public engagement. And allocation is not primarily the duty of physicians. We really want to highlight that this is a matter of shared responsibility. Such a translational process is both a transdisciplinary institutional challenge and a shared multi-actor responsibility at various levels of action, so society and the public, healthcare system, and science. And a second key conclusion of our research is for us, we need to talk about allocation, about fairness and equity, not just in times of a pandemic. The progress we have seen in medicine and health care over the last few years is forcing us to come up with frameworks for decision-making that are responsible, reliable, and trustworthy. It is imperative that we initiate debates on how we are going to tackle the challenges of allocation and the potential tension between individual and public health needs. And I would like to cite Erin DiMartino here. She summarized, these distribution questions are questions of fairness, questions at the heart of a just society.
Thank you so much. That was a fantastic summary, and that quote brings it home, the shared responsibility that we all have that goes beyond just the clinical realm. Any final thoughts from the two of you on this study or future issues in this area?
So Kathrin and I, we have two different things. We have some further issues and final thoughts. What shall we start with first?
Let's start with further issues, and then we can move into final thoughts.
Okay, there's another thing that I just wanted to bring up or talk about, and that is what made analyzing so complex for us was the co-founding factor of overuse and overtreatment. And this might sound a bit even crazy to you, because so far we've just spoken about shortage of resources and limitations of treatment. But we also know that, especially in modern intensive care medicine, unnecessary or even harmful treatment happens for a variety of reasons which are outside the scope of our study. But to illustrate this, I have a bit of a crass example from the interviews. Here's another quote from the study. One intensivist reflected the pandemic and said to me, well, if someone deteriorates and needs intensive care, we normally just admit them and then see where the road leads us. Okay, I exaggerated it. But once we had no beds left, then we really started to investigate. What would the patient have wanted? What was in their best interest? And we learned that participants were more cautious with admitting patients to the ICU. They set new standards, and some could even be called crisis standards of care. We heard very dramatic examples of withholding care that would normally be provided. But what was also really interesting to us is that it appears that by chance, the resource shortage forced some clinicians to reduce overuse of resources and made them reflect the appropriateness of their treatment.
Yeah, that's something that I thought about a lot myself during the pandemic. Is that, we learned a lot of ways to maybe not overtreat or over medicalize things that otherwise we would have. So that's a interesting takeaway from sort of the other side of the pendulum. Kathrin?
Yeah, from my side, looking at the shared responsibility, I would point out some other things. So I would like to thank the team at our university hospital and at the institute. So at the time of the pandemic, we were really thankful that the hospital board, the heads of departments, and all professionals involved in the implementation process and the simulation study were so supportive and engaged. And many thanks for that, particularly to Professor Schneider and Dr. Markus Heim from our department for anesthesiology and critical care. And during the process of study conception and data analysis, during the whole research process, we really appreciated the interdisciplinarity of our research group. And we would like to thank the philosopher Lukas Meyer, Marie Fritsche as a qualitative researcher, philosopher and physician by training, Katharina Adaktulos-Sorba, a doctoral student who worked on the simulation study, Stuart Beck-Lennon as a director of research, as well as other members of the network of qualitative research, and of course, the head of our institute, Professor Alena Büchs. Taking such a transdisciplinary approach was and is extremely helpful. We are so grateful for this shared experience, and we will continue our work on these sensitive and tough topics. And as you mentioned, there are a lot of other questions connected with this. And finally, we also would like to thank you for inviting us to be guests here on the CHEST podcast.
Thank you both for being here. This is an exceptional topic, exceptional work, and highlighting all the people that played a role in this work coming to us is really illuminating. Any last thoughts or final words before we sign off?
I think I'll start. I think the pandemic had a great impact on everybody, but especially on the intensive care community, and it brought up questions of distributive justice. But to me, it just starts a lot earlier when you look after vulnerable and dependent patients under the everyday time and resource constraints that we experience. But at the same time, modern medicine offers us incredible options to treat the most difficult cases and prolong life far above the average life expectancy. So I think what it's important to remind yourself that at the absolute micro level as a clinician, when you plan your tasks for the day or you set up a treatment plan, you should combine medical and ethical decision making. But the latter is, I feel, often a bit neglected, and this is what motivates me to take part in this research.
Yeah. And in addition, what Eva said, we wish to have more research on these translational ethic topics, on implementation science and development that include affected communities and marginalized groups and the public. And humility and ongoing learning are vital, as is being open, curious, and honest. And thank you again so much for having us.
Thank you both for being here today and discussing this fantastic article, Covert Triage During the COVID-19 Pandemic, Qualitative Analysis of Rationing in Intensive Care. Again, I'm Matt Siuba for the CHEST Journal podcast, and we will see you next time.